And welcome to today's Diabetes Prevention and Management Community of Practice. Thank you all for joining us today. And we've got a great presentation for you all, including diabetes prevention coverage, conducted by our subject matter expert, Joanna Di Benedetto. On today's agenda, we'll do some brief introductions and an icebreaker. We'll go over our learning objectives. We're going to have our data steward talk about framing the topic in data today. Then we'll have our subject matter expert provide the main presentation on diabetes prevention coverage, the payer landscape, revenue opportunities, and organizational benefits. We will save a few minutes at the end for questions and answers, and please feel free to also drop in questions in the chat at any time, raise your hand, or come off mute if you think of it as the presentation goes. We're going to wrap up with some closing remarks and a few announcements as well. So for today's intros and icebreakers, please introduce yourself in the chat with your name, title, and organization. And for today's icebreaker, in 1 or 2 words, let me know what comes to mind when you hear diabetes prevention. Again, please introduce yourself in the chat with your name, title, and organization. And let us know in 1 or 2 words what comes to mind when you hear diabetes prevention. All right. Thanks, Latrice. Improving health, I see. Hey, Tessa. Thanks for joining today. Lengthy. It's a good one. It's something we've heard before as well. All right. And continue adding those in the chat. We'll move right along with our learning objectives for today. Today, we want to understand the key payer types that support coverage or reimbursement for the national DPP or Medicare DPP. We want to recognize revenue opportunities associated with delivering the national DPP or Medicare DPP. We want to identify the strategic and operational benefits to becoming a national DPP or Medicare DPP provider. And we want to apply foundational program and reimbursement knowledge that we learned today to deliver these programs. And to start off, we will have our data steward lead the session off with framing the topic in data. So with that, Samia, I'll hand it off to you.
Thanks, Mariana. You can go on to the next slide. Good afternoon, everyone. Before we get into the main agenda for today, we just wanted to walk you through some of the data and what it is saying about the state of chronic disease in DC and the need for increasing patient engagement in DPP programs here in the district. As we all know, chronic diseases like diabetes, heart disease, and stroke don't happen all at once. It develops over time. Demographic factors like age, race, and ethnicity, metabolic factors like either being overweight or certain genetic factors, and clinical conditions like having a family history of the disease or taking medications for some health conditions put an individual at risk for developing these conditions. While these are non-modifiable risk factors, certain factors are within our control, like being physically inactive or following unhealthy eating patterns. Bad sleep hygiene increases our likelihood of developing early-stage diseases like prediabetes and obesity. And if continued to be left untreated, this eventually leads to chronic diseases like diabetes, heart disease, stroke, and related complications. From this disease progression chart, it is evident that it is possible to prevent chronic disease at several points along this pathway if we act early. Clinical support, routine condition monitoring, and healthy behaviors allow for early disease identification, early intervention, and eventually to prevent disease progression. Small behavioral changes like routine doctor's visits to monitor blood sugar levels, modest weight loss, The recommendation is at least 5 to 7% of body weight, and integrating at least 30 minutes of physical activity, like a brisk walk, into our daily routine can substantially lower the risk of diabetes. The National Diabetes Prevention Program, or DPP, is a structured, evidence based lifestyle change program that supports individuals in adopting these healthy behaviors to make lasting changes. It is a wholesome intervention that is impactful at any stage of disease progression, but especially at the early stage of the disease to prevent or delay type 2 diabetes. Next slide, please. Prediabetes often goes unnoticed. Most people do not know they are at risk until the disease process is already underway. Here we see data on the state of prediabetes in DC per Burfis 2024 reports. Approximately 1 in 7 DC residents had prediabetes in 2024, but the burden was not evenly distributed. Ward 7 shows the highest prevalence, with almost a quarter of adults being diagnosed with prediabetes. Non-Hispanic Black African American residents had 3 times higher rate of prediabetes compared to non-Hispanic white residents. Adults over 65 years had 5 times higher rates than younger adults. And residents with lower education levels had 2 times higher rates than college-educated adults. Overall, prediabetes rates have been steadily increasing between 2020 to 2024. Next slide, please. And the picture is quite similar for obesity as well. Here we see data on the state of obesity in DC per Burfis 2024 reports. Approximately 1 in 4 DC residents had obesity, and similar to prediabetes, the burden was not evenly distributed. Ward 8 shows the highest prevalence, with close to half of adults here being diagnosed with obesity. Non-Hispanic Black African American residents had 2 times higher rates compared to non-Hispanic white residents. And residents with lower education levels again had nearly 2 times higher rates than college-educated adults. And the overall trend again shows a gradual increase in the prevalence of obesity in DC since 2020. Next slide, please. And the trend lines further demonstrate the health disparities in DC. The rates for both conditions are higher among non-Hispanic Black and Hispanic residents than even the overall rates in DC. And these are indicated by the red, orange, and the dotted black lines respectively. Per CDC reports, between 2017 to 2022, DC had about 3,000 new cases of diabetes, and around 44,000 residents were already living with diabetes between 2020 to 2022. Diabetes accounts for around 851 million US dollars in direct medical costs. Studies have shown that Americans with diabetes have medical expenses approximately 2.6 times higher than those without. So the increasing prevalence, the high health disparities, coupled with the economic burden associated with these conditions, highlights the urgency in addressing this situation. It is therefore important to increase awareness about the purpose and significance of early engagement in lifestyle change programs among patients with prediabetes and obesity, and connecting them to DPP programs so they can take action at a stage where prevention efforts would make a meaningful difference. Next slide, please. The DPP enrollment graph shows that there is some progress in patient engagement and site availability for these programs over the years, but the current reach is still quite small compared to the proportion of residents who would benefit from this program. Furthermore, we see fluctuations in enrollment over time, which could be attributed to barriers like lack of awareness, low referrals, poor access to these programs. The map further demonstrates how in-person access to these programs is very limited geographically, especially because we don't see a lot of sites, active sites in the high disease prevalence areas, that is Ward 7 and 8. Some steps we can take to mitigate this issue right now is increasing screening for prediabetes, counseling patients on the risk of prediabetes and obesity, increasing referrals and ensuring retention in DPP programs, and promoting awareness about these programs while creating a supportive environment for healthy lifestyle behaviors within your community. Next slide, please.
Thank you so much, Soumya. That leads very nicely into our main presentation for today, diabetes prevention coverage, the payer landscape, revenue opportunities, and organizational benefits. And that is presented by our subject matter expert, Joanna Di Benedetto. Joanna is a seasoned public health consultant specializing in scaling and sustaining the National Diabetes Prevention Program, or National DPP, with a focus on the Medicare DPP. For over a decade, she has guided state departments, payers, including both public and private insurers, healthcare organizations, and community-based organizations in implementing evidence-based strategies that expand access and strengthen long-term sustainability. So everyone, please welcome Joanna.
Hi, everyone. Thanks so much for inviting me to this call. And that was a very helpful overview of your landscape in DC. As mentioned, I'm Joanna De Benedetto, and I've worked in the National DPP for almost 15 years now. In coverage, I've been to DC quite a few times. You all have such a lovely and eclectic city with many different pockets and caveats, and just seeing those maps and kind of getting an understanding of where you are was really, helpful and interesting to me. But today I'm hoping to give you all some more insights on the payer aspect of the national DPP and of Medicare DPP. The one word activity at the beginning, I didn't play, but if I would have played, I always think of, upstream as being prevention, and prevention over treatment. Not that treatment is not important or needed, but the idea and the premise is that to hopefully meet a lot of these folks earlier on their health journey so that they can either prevent or delay diagnosis and development of type 2 diabetes. Next slide. I think this kind of goes without saying that, diabetes is affecting all of our communities, some more than others, right? As we just saw by those data points. But regardless of the factors, you don't really meet many people who've never heard of diabetes or who don't know someone who's developed diabetes. So it is relevant to many people, and also it is a costly disease state. So there's a lot of interest, and there's been interest for decades on how to invest in delay or prevention of the disease from the payer's point of view, because really they're the ones who will get that return on investment. Hopefully, if the covered lives that they're responsible for don't go on to develop or can delay development of type 2 diabetes and other comorbidity factors, they're the ones who really, for lack of a better term, reap the benefit or reap the reward, as well, of course, as the patient themselves. Next slide. Today we'll talk mostly, and again, these are a lot of stats. I love your local stats. I think they supersede these more national stats around, the prevalence of prediabetes. I noticed too in some of those diagrams, there was like a spike in prediabetes. I'm wondering if that was because maybe more people are being diagnosed with prediabetes, which would be a good thing, more awareness of it. Or maybe that could cause that spike. But either way, it's something that, although there's been a lot of efforts towards this for the past few decades, the prevalence is still rather high, and the cost is still rather high. So we haven't solved it yet, unfortunately. Next slide. And today we'll talk a lot about the National Diabetes Prevention Program and defining what that is. So this is something that CDC has utilized translational studies from the original DPP or Diabetes Prevention Program clinical trial that happened, again, decades ago. I think that there's been 25 years worth of data collected on this program. It's evidence-based. It is part of the national DPP is the lifestyle change program, is the curriculum. We'll talk a little bit about that, but really the shining gold star of this program is that it is based on long-term evidence that showed that those that go through this program can reduce their risk of developing type 2 diabetes by 58%, or even by 71% for people over the age of 60. So those numbers are, again, clinical based on a study, evidence-based, and have been studied for decades. Next slide. Many of you have probably heard of by now the Medicare DPP versus the national DPP. So I wanted to put up this infographic. This is from CMS just to show the differences, the nuances between the two. If you think of them, national DPP is more or less the same as Medicare DPP, just for a different group of people. So Medicare DPP is for Medicare beneficiaries, typically those over 65 in this country. There are some nuances. There are some eligibility differences. Their blood-based value for having prediabetes and being eligible for the program is slightly higher for those Medicare beneficiaries. And the organizational requirements for Medicare DPP versus the national DPP are more rigorous, but essentially an organization has to become a national DPP program before it becomes a MDPP program, and therefore able to bill Medicare for the program for the Medicare beneficiaries. Those are the main differences. Next slide. So who is paying for this program? Before anyone becomes a national DPP program provider or a Medicare DPP supplier, as they're called, it's good to know who and how you will be able to seek reimbursement for this program. So if you go to the next slide, there's a list of public payers. And apologies, the third row down, just ignore that. That was an old duration. But the two at the top are the public payers. So these are what tax dollars go towards paying. And that's Medicare, which we talked about a second ago. This is typically those over 65 have Medicare insurance coverage. That's a public payer. It's a national level, and the coverage of MDPP is 100% for eligible beneficiaries nationwide. The reimbursement for basically there's two ways to receive Medicare insurance. You can either go original, it's sometimes called fee for service or FFS, Medicare insurance. And the programs, the MDPP suppliers, the organizations seeking reimbursement would go through the Medicare administrative contractor or their regional MAC. And then we'll talk about Medicare Advantage in a second, because that's technically operates as a private payer. Then there's Medicaid, and this varies state by state. And I know you all are not a state per se, you are a region. I did look it up just to verify before joining this call, and it does not look like DC has Medicaid coverage at this point. It really varies, and it's a very interesting landscape of payers. But a lot of Medicaid coverage follows Medicare as far as the fee structure and some of the requirements. And then again, skip that next line. And then if we go down to Medicare Advantage plans, this for like a private coverage. They cover Medicare lives, but essentially they hold a contract with CMS and they're to execute the benefits of Medicare to their beneficiaries. So these are like the Aetnas, the Blue Cross Blue Shields, other types of payers that you've certainly heard of. And this is their Medicare Advantage plan for those over 65. They are also required to cover the MDPP. They're required to cover all of CMS's mandatory benefits. But contracting and working with them is a little trickier as far as, in-network and out-of-network coverage. We can talk a little bit more about that. And then, of course, there's the commercial plans and the employers, and these are private employers. There is not, unfortunately, at this point, coverage across the board for commercial plans, although more and more join this momentum of coverage. Every day there's a list I can share with you that's not a complete list. However, it does show many of the larger plans that do specifically cover the national DPP, and many employers see the benefits of this and do offer it to their employees as like a wellness benefit. So that does vary across the board. But again, a lot of these programs look to Medicare, look to CMS for how they should put together their benefits and what they should cover and why. So there's certainly data that goes towards that. Next slide. So as I mentioned, Medicare coverage does set the trends. Medicare is the government-sponsored health insurance plan for people over 65. It also includes end-stage renal disease and ALS. The Medicare DPP program has been included as a covered benefit since 2018. So we're, 6, 7, 8 years into this. Currently, they do have updated the payment rates just about every year into the program. So there's been efforts to make the payment structure incentivize organizations to participate. And it's currently at $782 per participant is the max amount that you can be reimbursed. It's a mixture of both attendance markers. You can be reimbursed just for the participant or beneficiary attending the program. And then there's also quite a good chunk of that 782 that goes towards if that person meets their weight loss objectives of 5% and an incentive payment if they reach 9% weight loss. And then, like I mentioned before, all other payers kind of look to Medicare as a benchmark. So even if you're not currently an MDPP provider or supplier or plan on becoming whenever, it's still good to know what they're doing in this space because if you're working in this space at all, other payers are looking at that. Next slide. And as you saw on that chart, the coverage varies across the payer types. Each payer can set up their requirements for the program for their the organizations that submit claims or invoices. Most payers require programs to be CDC recognized, and we'll talk about that a little bit more, what that means. And each payer might require credentialing. They might reimburse a flat rate or per attendance or only if the person meets the goals. So that kind of varies across the board too of how the payment mechanism is set up. We've heard of many programs that have negotiated higher rates or rates that are more payment for the organization upfront so that it's a little bit less risk for the organization of spending the time, marketing, onboarding, and enrolling someone. And that way they're insured to, at least break even if the person ends up dropping out, things like that. I do want to mention here that there's a type of mechanism that's increasingly becoming attractive to a lot of smaller, either community-based organizations or maybe smaller hospital systems of an umbrella hub organization. An umbrella hub organization is essentially specific to the diabetes prevention program, where one larger entity would contract with the payer. So they would contract with the commercial plan, or they would become an MDPP supplier and kind of do all of the billing. And then they would contract with a delivery organization to provide the program, and then they would pay the program based on whatever contract they negotiate. And that really does help the smaller programs who want to provide this to the community and provide this to the folks that are walking through their doors that they already have a relationship with, but they don't necessarily want to take on the burden of the compliance and the billing and the coding and the claims. And it can be a lot, especially for a smaller organization that's not already billing. So that could be a good option or a good setup if you're interested in being a part of this national DPP program, but not necessarily feeling like your organization has the capacity to go through all the hoops. Next slide.
Question in the chat, Joanna. Is it possible for health
Yeah.
departments to be umbrella hub organizations?
Oh, yes. Yes, I think we've seen one of those examples, which I'm happy to connect with. I can't remember off the top of my head who that is. They have to just be comfortable with billing. And you can hire a third-party billing administrator to help with that component as well. So we can talk to you all more about that. I can't remember off the top of my head, but I will get back to you on that, who that state health
Okay,
department is.
perfect. Thank you. Thank you, Tessa.
Yeah, good question.
Yeah.
Okay, so let's talk about becoming a CDC recognized organization. Again, I mentioned before that there's a strong evidence base. A lot of programs will just say, well, we deliver prevention. We do like a 6-week prevention program, or we offer, classes as needed. The idea around tying it back to the national DPP and CDC's national DPP program is that you can tie it back to the evidence. So again, that then ties the payers into that return on investment, that the cadence, which is frequency and duration of a 1-year program where they're meeting about weekly for the first 16 weeks and then usually monthly for the second 6 months of the program, that is kind of where all the secret sauce is in the success of the program. Many of you in your one word said like lengthy. It's a lifelong commitment. It takes time. Of course, we're seeing all the GLP injections where people can more or less easily lose that 5 to 7% weight loss, or even more in a lot of cases. But then how quickly does that weight creep back if they go off those GLP-1s, right? So this is where we're talking about not only losing that 5 to 7% weight loss, but then maintaining it. That is the component that is, makes this program so valuable and so long-term, is that folks are learning skills, and then throughout a year, a lot of things happen. There's birthdays, there's anniversaries, there's weddings, there's holidays, there's all these things that come into a person's life where the program helps them figure out how to continue to manage and make time for those healthy components that they're able to really put into practice. The Medicare population, there was a demonstration specifically with the Medicare population a few years ago to deem if CMS, if federal dollars essentially was going to be given to cover the Medicare DPP. And they kind of did a translational study just with Medicare beneficiaries, and they were shown to be effective. So there's a lot of data, a lot of research, and a lot of evidence around this specific program versus the other, maybe shorter or smaller one-off prevention programs. And there's also the fact that CDC has these standards and that it has kind of this brand and support and connectivity across the payers. Next slide. I think we talked about, the 10 and 15-year follow-up studies. So this is where, the cumulative diabetes incidences were lower. And, we know that people, again, are being prescribed with a GLP-1s, and a lot of times that can accomplish that weight loss. But looking at, it's just a newer prescription, and looking at, is that weight loss being able to be maintained by those individuals for long-term lifestyle or life health impact, I should say. And just to frame that, I don't think it's a either or. I think oftentimes it's a both and, right? Can the person be on that prescription and be part of the national DPP program or MDPP, learning the skills and the things that they need to know in order to maintain those benefits? Next slide. So we talked about the CDC National Diabetes Prevention Program. The actual place in which you would register your organization would be the Diabetes Prevention Recognition Program, or DPRP. So this is where there's the list of or packet of standards that all national DPP CDC recognized programs follow. They submit data to CDC every 6 months on who they're serving and how much weight they're losing and what the attendance is like, so that CDC maintains that consistency across the program. There's also a variety of different approved curriculums, including translation into various languages that CDC has approved to make sure that the curriculum is standardized. But I will say that the curriculum is also always able to be enhanced by your specific population, or if you want to do a field trip to a grocery store, all different, or have a cooking class. There's a lot of room and flexibility to make sure the program is relevant to the population you're serving. But there are certain topics that they want to make sure everyone is receiving. And then that registry of programs all are listed on CDC's website. So that way, again, a payer can go look and make sure that, that program that they're working with is part of the CDC's national DPP. Right now, there's about 1,500 CDC recognized programs. Next slide. So CDC recognized organizations and or MDPP suppliers, because again, to become an MDPP supplier, you're first a CDC recognized organization, and then you go through a CMS application to become an MDPP supplier. But these are all the great things that you all can do and contribute to if you become one of these organizations. You can, of course, improve health, expand access to quality care. Again, the standardization, the tie back to evidence is all really important to be able to say that the program is a quality program. The participant and beneficiary satisfaction, sometimes it's a hard sell to ask people to commit to a year-long program, and we know that that's, one of the harder things, or the barriers a lot of time for people. But it's one of those programs that for the most part, once people are in, they feel committed, they feel accountable to their small group. The small group process gives them a social component, as well as a relationship building that people really seem to adhere to, especially in the modern days of technology, where you're not necessarily connecting with people as often or for as long a period of time. So there's a lot of positive anecdotal feedback from a lot of the recipients. And then, going back to those healthcare costs, if we keep going the direction we're going as a society, covering the cost for, if all the people right now that have prediabetes go on to develop type 2 diabetes, it would be a huge cost collectively for us all to figure out how to ensure everyone is, getting the medication and treatment they need. So it's one of those things that, we have to continue to drive upstream and look at the preventative measures and encourage and motivate people to do something now while they still have the time to hopefully affect their health in a really measurable way. Next slide. So the big question for today, should your organization become a CDC recognized DPP provider or an MDPP supplier? My questions to you would just to be to think about, are you already serving people with prediabetes or other chronic conditions? We talk to a lot of diabetes self-management education programs who are already, essentially some people will walk in their doors and have prediabetes and they weren't sure exactly where to send them or what to do. Do you screen already for chronic disease programs or chronic disease prevention programs or other kind of health programs? There's a variety of chronic disease prevention programs. So if you're already doing one, working with the national DPP might be just another source of either revenue for you or another touch point with a lot of your community that you're serving. Do you already bill Medicare or other payers for services? If you're already a diabetes self-management education program and you're billing Medicare, or if you're, completing medical claims for other things, you probably already have the infrastructure needed. So, again, adding another source of revenue to that might make sense. If you're not, and you don't think, again, that building it out just for MDPP makes sense, probably. I mean, just to build all of that out just for one program might not be sustainable, but if that's a direction that your organization wants to go in, certainly this could be one of the programs that you provide and that you bill for. Does your organizational mission or values support chronic disease prevention through healthy lifestyle? I mean, that's a critical question. Is your leadership going to be supportive and have buy-in? That's a really important component of being successful in this program, is having that leadership support, because it is going to take staff time and marketing and connecting with physicians for referrals. A referral is not required for the national DPP or for MDPP, but certainly that is the most volume of participants we tend to see in the program is from healthcare provider referrals. They may or may not do what a flyer suggests they do, but if their doctor tells them to do it, they're more likely to join the program. And then another question you have to ask is, if you're not ready or interested in becoming the CDC recognized organization, how else could you be involved? Could you be a delivery site or a subsidiary of an existing umbrella hub organization? Could you refer people to the program, to one of your fellow programs that are on the call right now? So, how can you continue to promote the program even if you're not directly a provider of the program? And noted here is that if you are a DSMES or DSMT program ADA accredited ADA recognized or ADCES accredited, CDC does let you jump the line to become an MDPP supplier. So normally you have to wait 12 months when you become a CDC recognized DPP provider. You have to wait 12 months, submit data to kind of show that you're on the right path before you apply and become a Medicare DPP supplier. But if you're already a DSMT program, they let you go forward. So that's another advantage if that pertains to you. Next slide. I do want to make sure to leave you with some resources. This is a quick presentation and there's been a ton of material. Again, this has been CDC's national DPP has been around for decades. So there's a plethora of materials that can help you understand more about what the program is and how to market it and how to talk about it to participants and what does the data collection look like. So CDC has a customer service center geared towards organizations. That talks about the operating procedures, training, the lifestyle coaches who will deliver this program. The coaches do not need to be Medicare profession or medical professionals. They can be anyone really who attends a training and is willing to be dedicated to the program. There's applying for CDC recognition, which is relatively quick and easy, although, of course, the process of delivering the program is more intense, but the CDC recognition part is pretty quick. The curriculum and the handouts and the resources, again, have been built out, and there is a lot there for everyone. The next resource is the coverage toolkit. This is really focused on payer and reimbursement of the national DPP. So when I mentioned there's a list of the payers, you can find that here on the coverage toolkit. It is split up by payer type, so you probably can't see, it's a little small, but at the top there's Medicaid coverage. There's a whole section on Medicaid coverage. There's a whole section on commercial payers, a whole section on Medicare, and then a whole section on umbrella hubs and how to be more involved in that. And then, of course, we have various additional materials on specific populations, and again, resources and best tips and practices galore on all things coverage of the national DPP. And links to CMS. CMS also has a specific section on MDPP where they, again, have webinars on billing and webinars on how to enroll as an MDPP supplier. So CMS is the go-to for MDPP. But if you go to the next slide, we've also built some tools over the past few years, business tools. And these resources might help you up front in, again, making this decision on whether or not you become a CDC recognized organization or an MDPP supplier. There's a revenue projection tool so you can get very specific with, how much revenue could I actually generate if I offer this program. A participant enrollment planning tool, which can help you kind of project how many participants do you think you'd be enrolling and how many cohorts can you launch and what would the staffing look like. And then there's a capacity assessment tool, which goes through question by question and gives you a result at the end, helping to identify gaps and places where you may or may not want to invest more infrastructure in before you submit these applications or decide to submit these applications. So I think those are all the slides I have. I'm happy to answer questions that have come up throughout the presentation or anything regarding national DPP and MDPP.
Wow, that's great. Thank you so much, Joanna. Yes, this is a time right now for a Q&A. I do have some just open discussion questions. Feel free to come off mute, type your questions in the chat, but just some things to think about. Any differences that you've seen between payer types when it comes to supporting DPP, revenue opportunities that stand out as most valuable or realistic for your organizations, any strategic reasons that might motivate your organization to offer national DPP or Medicare DPP, and what first steps could you apply within your role to explore feasibility to become a provider of the DPP program here? So would anyone like to come off mute and share any questions, thoughts? Feel free.
Hey everybody, it's Tessa from the Y. We had tried to apply to be a Medicare provider years ago. It's a really complicated process for a CBO that's not necessarily like a health focused CBO. And so I'm definitely we'd love to be able to bill. I think it's super important for sustainability. And I think for us, what makes most sense is joining a umbrella hub. And there's other Ys across the country that have done this. You don't have to join a hub within your state, but obviously a local hub would be better. So just reiterating my support for you guys forming an umbrella hub that the rest of the district DPP providers could join, and we can bill via an organization who has the capacity to take that on.
Yeah, thanks, Tessa. I'm definitely working toward something here at DC Health. I know I'll hand it over to Amanda, but previous is just like getting that Medicare coverage, Medicaid coverage for our diabetes programs here has been a long process. But we are working toward it. Yeah, and I agree, it would be great if we could be your umbrella hub organization. So yeah, definitely something for us to think about. Any other
Now, the
questions?
other advantage of the Umbrella Hub organization is not only for the entities that might fall under that don't have the capacity again to bill, because it is, even the application process, as Tessa said, is a big lift, let alone keeping up with the billing and claims process. But that the Umbrella Hub has more leverage with other payers. So other payers are more likely and probably more interested in doing one large contract to cover a multitude of delivery locations than individual small contracts. They might not even have a meeting with you if you're just serving, 10 of their members a year or whatever it might be. So there's a lot of benefits, not only for the organizational side, but also for the payer contracting side.
Is there a minimum of organizations that you need to have, like to become an umbrella hub organization, the main one? Any minimum, maximum number that you would have to supply to or assist with?
That's a great question. Maybe there's a minimum, but I think it's like one or two. I think you
Okay.
have to essentially have the infrastructure. I can get back to you on that. I'm not as well versed in any updates with umbrella hubs, but I know of umbrella hubs that have like one or two locations.
Okay. Great. All right. And we'll move it right along if no one has other questions.
Question.
Go
I
ahead.
have a
Yeah, go ahead,
question.
Shannon.
This is Shannon. Hi, Joanna. What are for organizations that have a DPP or have been able to successfully launch a DPP program? What are some of the most common threats to sustaining their program that you see, and some strategies to mitigate that?
Yeah, I mean, I think, kind of going back to the capacity assessment that we've built or thinking through that, we actually built the capacity assessment based on 60 MDPP suppliers and like their feedback of what they wish they had known or what was their key to success. And again, I think, having that leadership buy-in, leadership support that's willing to invest on the front end around, staff time and training and then having that referral chain as already a component of your program, because it is really difficult to say to a physician, oh, just talk to these certain patients that have this certain type of insurance or that fit this certain age that we serve. If you can serve multiple payer types, multiple patient age groups, and really, provide programming for meeting people where they are on that, chronic disease path, that tends to have be very valuable to the success of a program, of having those referral chains. Are you already in an embedded electronic medical record? Can you do bulk polls of people within these prediabetes range? Can you reach out to them and connect with them on behalf of their health system that they're in? Those seem to have more traction around people's interest in enrollment, because unfortunately this is not the kind of program where if you build it, they will come. That was kind of seen a while ago, where they built a lot of programs, they trained a lot of people, they were ready to implement the program, but people weren't being sent to the program. There wasn't a lot of uptake in the program. So now we've learned a lot about making sure like the referrals are being pushed to the program so they don't have to do as much outreach. They can focus on the delivery and then of course the billing aspect. So those are probably the two components.
That was helpful. Thank you.
Yeah, thank you so much for sharing, Joanna. Any other questions? All right, we still have a few minutes, so we'll move along to our closing announcements. Thank you all for a great discussion and sharing all your insights. And as we wrap up today's session, a few quick announcements to share. We do want to give our partners some time. If anyone has any announcements or upcoming events they'd like to share, feel free to come off mute again or type it in the chat. And again, this session is being recorded, will be shared and available soon on our livingwelldc.gov site. Our next Diabetes Prevention and Management Community of Practice session will be in July. So no session next month. And the next date is set for Tuesday, July 28th from 2 to 3 again. And I will now go ahead and launch the poll and stop sharing the screen. So 1 second. And just give it a few minutes to load. Here we go. All right, and I'm gonna go ahead and launch it now. Feel free to add your responses to the poll, and you may go ahead and have a wonderful rest of your day as you answer those questions. Thank you all for joining today. Again, we'll see you all again in July.
Thank you, everyone.
Thank you.
Thanks all. Thanks DC team. We'll be in touch.
Thank you, Joanna.
Thank you, Joanna.
Thank
Take
you.
care.